Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Johnson & Johnson.
Hello, everybody. Thanks for joining us. I'm Roger McIntyre, professor of psychiatry and pharmacology at the University of Toronto. Welcome to our program entitled Beyond Sedation, Reexamining Insomnia as a Core Symptom of Major Depressive Disorder, MDD, the role of novel Orexin-based strategies. And if I was to step back a step, I might say this is an example of theory to therapeutic, a very interesting new target in the area of major depressive disorder. Thanks for joining us here today. I'm not alone in this endeavor. I have a number of colleagues and also a patient advocate. Natalie Smith will join us from Philadelphia, Pennsylvania. And our faculty is comprised of Dr. Sophia Khan, who is the Associate Professor, Department of Family and Community Medicine in the Department of Neurology, and Program Director of Sleep Medicine Fellowship in the great state of Texas, University of Texas Southwestern Medical Center in Dallas, and also Dr. Carl Ramjeev, who is the Professor of Emeritus, Psychiatry, Human Behavior, and Neurology, Sidney Kimmel Medical College, Thomas Jefferson University, and a sleep medicine specialist at Phoenix Free Clinic in Phoenixville, Pennsylvania, United States. So a big time thanks in advance to Natalie and my colleagues joining us for today. I want to get started very quickly if I can. We have some really interesting new data we want to discuss with you. Just to start off the conversation, we have many conventional, evidence-based, FDA-approved antidepressants, and we also have manualized-based psychosocial interventions, all of which collectively have been proven to be very effective. They have changed people's lives. They have saved people's lives. But the other reality that coexists is that the great majority of people with major depressive disorder have an inadequate response to antidepressant therapeutics, not just the first treatment, but multiple sequential treatments alone or in combination. And results from many studies, which align with the famous STAR-D trial, indicate that at the end of multiple treatment trials, 3 to 4 to be exact, only about 35% of people actually achieve a remitted state. And what we've also learned is that those who do achieve remission beyond the first treatment, that is the second or third treatment, and so on and so forth, higher risk of relapse and also a higher risk of intolerability of therapy. All this is to say is that we need new treatment targets, and we need new treatment targets for individuals who are inadequately benefiting from the first-line antidepressants. And again, turns out that 2/3 to 3/4 of people are having an inadequate response. We all agree that functional recovery is the overarching goal of treatment in major depressive disorder, and it starts with attempting to achieve a fully remitted state. Over the last decade and a half, there's been intensified efforts to identify which specific aspects of depression, when people are living with this condition, are most contributory to impaired functional outcomes? Well, one area is, in my sort of description, would be parsimoniously described as disruption in arousal. Patients have anxiety, often have a lot of insomnia. Now, we all know that disturbance in sleep has been a characteristic described in depression going back centuries. In the DSM-5 text revision, which is the most recent iteration, sleep impairment is a core feature of depression, one of the criterion items. These sets of studies we're sharing with you is telling you a slightly different story, and that is that amongst people treated with antidepressants such as SSRIs, a large percentage continue to have residual sleep complaints. So sleep is one of the criteria features. It's often residual. There's a separate line of research that says that sleep impairment might be a precursor to depression. All this is to say that there's something about the behavior of sleep that might give us hints about the underlying neurobiology that have really, in fact, shaped the way we rethink new targets in depression, especially in people who are having an inadequate response to antidepressants. So, with that in mind, I now want to just pass the baton, so to speak, over to Natalie, who will discuss with us sleep as a residual symptom in depression. Natalie.
Hi, I'm Natalie. I work in the nonprofit world and I'm an avid hiker. I'm in my 40s and I've experienced depression since about the end of middle school, early high school years, but I didn't get officially diagnosed until my mid 20s. In the last decade, I also started to experience significant insomnia, which worsened a lot in the last year and a half after a difficult breakup. And I've had trouble finding effective medication for my depression and insomnia. So I utilize a combination of strategies and have participated in psychotherapy on and off for the past 2 decades. My depression and insomnia are inextricably linked. When I'm in a particularly low period, my insomnia noticeably worsens. For me, insomnia presents as intense rumination at bedtime, which means I take a very long time to fall asleep, which means I then stress about how long it's taken me to fall asleep. And my insomnia also involves waking up about 3 hours earlier than I'd like to, and then being unable to fall back asleep. I also find that during particularly hard stretches in my depression, I'm very sensitive to environmental factors that impact my insomnia, like light and sound. So I've had to do a lot of work to manage my environment. Until very recently, I worked a job that required that I be on call overnight and able to both make veterinary medical decisions overnight as well as be able to drive on site to handle after hours emergencies. And those circumstances created a challenge for finding a medication that could address my insomnia but not impair my judgment for those phone calls or make me unable to drive. Um, Fatigue. Because my insomnia results in less sleep, it exacerbates the fatigue I usually already experience with my depression. And that then activates a lot of the self criticism and self judgment that I struggle with when I'm depressed. So it really becomes a vicious cycle. The fatigue impacts my readiness for activities that I know would otherwise help my depression, like exercise, whether it's the gym or hiking, just not having the energy or motivation, and also social activities with friends, which again, I know would help, but I just feel too fatigued. And then cognitive impairment. So, sleep deprivation from insomnia has a huge impact on my cognitive functioning, both my concentration and decision making. I can't tell you how many times I've said to friends, family, and my partner that I have decision fatigue. Everyone's tired of hearing it. And when you pair that decision fatigue and depression with having to drive your own mental health treatment plan, it can make your mental health issues feel really insurmountable. And so for me, that means it's really important to have a supportive, proactive, decisive clinician on my team. More broadly, the impact on my concentration really impacts my day to day life. For example, I used to be a voracious reader, but for the last year and a half, I was unable to read at all due to my lack of concentration and slipping into rumination. I also noticed my lack of concentration impacting my work. And the cognitive impact from insomnia and depression also includes just in general feeling less resilient to events and stressors that exacerbate my depression. So day to day hiccups that should just be frustrating or annoying feel overwhelming and feel like they take an outsized toll.
Well, I think Natalie's description of this insomnia difficulty nicely highlights how impactful this can be in terms of not only sleep functioning but daytime functioning as well. What exactly causes insomnia? Well, the going hypothesis is that there's a system of hyperarousal that where the body remains persistently on, body and the brain remain persistently on or overactivated when they should be winding down for sleep. In essence, the wake switch needs to be turned off to allow sleep to occur, but it remains on. This, we think, is mediated through a variety of wake promoting neurotransmitters such as histamine, dopamine, norepinephrine, serotonin, and also the orexin system, which we'll talk about in a couple of minutes. And it's really a 24/7 phenomenon. During the day, insomniacs are also hyperactivated, and they say they're tired but wired. This hyperactivation or heightened arousal system we think leads to various issues, and is seen in various systems, such as the brain. We see brain hypermetabolism, body hypermetabolism, EEG speeding, cognitive arousal, the mind is spinning, hypothalamic pituitary axis activation, such as elevation in the 24-hour cortisol output, and metabolic hyperactivation. We see insulin resistance, reduced glucose tolerance, and higher blood sugar levels. Higher heart rate is increased. It's not surprising that long term cohort studies have shown that the chronic insomnia increases future rates of development of hypertension, diabetes, even coronary artery disease, and congestive heart failure and dementia. Now, insomnia is a key symptom of major depression, but also its very presence and persistence also seems to predict the intensification of depression and development of future depression. We know that if it persists as a residual symptom of depression, it predicts the onset of greater depression and lack of remission. A number of cohort studies have shown that that insomnia predicts the new emergence of depression in the future. The 21 studies that have shown this with an odds ratio of 2.6. Not only depression, but also anxiety disorders and substance use disorders. Interestingly, insomnia is strongly associated with suicidal ideation in the context of major depression. We also know that a number of treatments of insomnia have shown that we can actually have a positive impact on underlying psychiatric aspects. For example, insomnia treatment in the context of treated major depression can lead to diminution of suicide ideation and hypnotic management and CBT management in the context of depression can lead treatment of insomnia can lead to more rapid onset of remission. So we know that there is this we bidirectional relationship between insomnia and depression. One leads to the other and intensifies, and they seem to intensify one another. Now, the what is the role of rumination? This idea of rumination or mental spinning this is a cognitive correlate of hyperarousal and may explain why insomnia can become self perpetuating in the context of major depression. In essence, the brain doesn't shut off. The mind keeps spinning and spinning. And insomniacs will say this I lie in bed and my mind is just spinning all over the place. This rumination also can focus on poor sleep and lead to anticipatory anxiety about further sleeplessness, in essence, becoming a self fulfilling prophecy leading to even further increased arousal at bedtime and worse sleep. This autonomous cycle contributes to the development of a chronic insomnia and contributes even more to the intensification of depressed mood. Now, the orexin system is a key system in sleep and wakefulness. We don't learn a lot about the orexins. We haven't in psychiatry. We haven't seen much discussion about the orexin systems, but these are key neurotransmitters in the whole realm of sleep and wakefulness. These are hypothalamic peptides that are localized to the dorsolateral hypothalamus, and they have wide projections throughout the brain and the spinal column and act as neurotransmitters. They control in animals a wide variety of functions, including arousal, wakefulness, locomotion, metabolism, and even blood pressure and heart rate. And they also, importantly, control the activity of other arousal systems, such as norepinephrine, histamine, serotonin, and so on. they also coordinate the proper balance between sleep and wakefulness. These, of course, are deficient in narcolepsy, leading to sleep-wake imbalance, or the confluence of sleep and wakefulness, and therefore people are sleepy during the day when they should be awake, and not sleeping well at night when they should be sleeping. Some people have theorized that the orexin system may be deranged or dysfunctional in insomnia. That is, there's a inappropriate hyperarousal of orexin, the orexin system, in the case of insomnia, and this is also possibly the insomnia depression. So orexin signaling may be inappropriately elevated at night, causing difficulty falling asleep and frequent nocturnal awakenings. Now, orexin or hypocretin signaling operates through two G protein coupled receptors, orexin type 1 and orexin type 2. These have overlapping but very distinct physiologic functions. Orexin type 1 has the primary role, we think, of reward addiction, and it has also important aspects of controlling motivational aspects in stress and emotional arousal. Antagonists of the orexin 1 system are being developed for the substance use disorders and anxiety disorders, and they modulate sleep function. On the other hand, orexin type 2 receptor is more important in terms of controlling sleep-wake stability. It's the primary driver for wakefulness and maintains a consolidated wakefulness system. Orexin type 2 agonists are being developed for the treatment of narcolepsy. The dual orexin receptor antagonists, that is, antagonists which antagonize both the orexin 1 and 2 systems, promote sleep. We know that these agents exist currently, such as daridorexant, lemborexant, and suvorexant, and reduce wakefulness drive and dampen the arousal and stress systems. On the other hand, we'll see more about this in the next few slides. Orexin type 2 antagonists, so that are selected for the orexin type 2 receptor, are being developed, which have been shown to reduce nocturnal hyperarousal, improve sleep continuity, and enhance slow wave sleep, and in turn, improve sleep and maybe also improving mood.
Thanks, Carl. I'll go over some data from phase 3 and phase 2 studies for a few of the orexin antagonists. So, based on the phase 3 Sunrise 2 clinical trial, lemborexin demonstrated significant long term efficacy and generally well tolerated in adults with anxiety and depression who were treated for insomnia disorder. Both the 5 and 10 milligram doses significantly improved reported sleep onset and sleep maintenance compared to the placebo group. And these benefits were maintained for up to 12 months of continuous treatment after end of therapy. Participants reported meaningful improvements in overall quality of sleep and morning alertness throughout the study period. And in a group or subgroup of 61 patients from the Sunrise 2 trial who were also receiving treatment for depression and anxiety, it showed that lemborexant treatment benefited these patients by helping them fall asleep and stay asleep more effectively than placebo. However, in that group, the placebo response was significant and that slightly decreased the overall drug versus placebo effect. For side effects, the most frequent treatment emergent side effects were headache, somnolence, daytime sleepiness, and nasopharyngitis, like a common cold symptoms. And rates of these serious side effects were low and comparable to placebo. For this phase 2 study published by Connor found that the orexin receptor antagonist philorexant at doses of 2.5 to 20 milligrams significantly improved sleep efficiency and maintenance in non-elderly adults with primary insomnia compared to placebo. Results indicated dose related improvements in both sleep onset and sleep maintenance, with the drug maintaining a favorable tolerability profile over the 4 week randomized crossover trial. However, a significant improvement on the Montgomery Asperg Depression Rating Scale was not observed at the trial doses. In this specific proof of concept trial, some of the adverse events occurred over more frequently with philorexin compared to placebo. And these specifically include drowsiness, reported in 7.8% of the philorexin group compared to 0% In the placebo group, suicidal ideation was reported in 7.8% of participants on Filorexin versus 1.6% on a placebo. And headache also occurred more frequently in the Filorexin group. So development of Filorexin was discontinued in around 2015. This was likely due to lack of efficacy, clear efficacy in non-insomnia conditions like anxiety and depression, and a lack of significant clinical advantage over Suvorexant, which is now FDA approved. Results for the Suvorexin and Esopiclone trial. For these patients taking Suvorexant and Esopiclone, they had improved insomnia in the determined by insomnia severity index scores. So minus 4.3 for Suvorexin and minus 4.1 for Esopiclone at week 4. And both drugs tended to improve the Beck depression inventory 2 and generalized anxiety disorder 7 or GAD-7 scores at 2 and 4 weeks after switching. And the Pittsburgh Sleep Quality Index version digit symbol substitution test, all of these did not show significant change from baseline. So essentially, switching to Suvorexant or Esopiclone was well tolerated and improved the severity of benzodiazepine unresponsive insomnia in patients with major depression. And both drugs could be beneficial alternatives to benzodiazepines for treating insomnia in patients with major depression. So in a 2022 study, switching from benzodiazepines to Suvorexant or Esopiclone for insomnia in patients with major depression was well tolerated with no significant increase in side effects. Um, okay, for the safety data, insomnia severity reduction in patients with depressive symptoms was significantly more pronounced in patients with higher baseline sleep disturbance. So, for those with a higher ISI, more than 15, these patients had significant improvement. Mm, okay, and then this is the Seltorexant phase 2b study. The study utilized a mixed model for repeated measures to assess the change from baseline compared to placebo. And some key subgroup findings include that the insomnia severity reduction in depressive symptoms was significantly more pronounced in patients with higher baseline sleep disturbance. So, for patients with ISI more than 15, the LSM at 6 weeks was minus 4.9. And for other doses, the 40 milligram dose showed numerically less improvement compared to the 20 milligram dose, and the 10 milligram dose did not significantly differ from placebo at any time point. And when stratified by the presence of moderate or severe insomnia at baseline, improvement in depressive symptoms were significantly greater with the 20 milligram seltorexant dose compared with placebo, as well as with both 10 milligram and 40 milligram doses of seltorexant at week 3. At week 6, 20 milligram seltorexant was more effective in improving depressive symptoms than placebo, and the 10 milligram seltorexant dose, but not the 40 milligram seltorexant dose, especially in individuals with moderate or severe insomnia symptoms at baseline. And in the absence of moderate or severe insomnia, improvement with the 20 milligram dose of seltorexant was similar to placebo and other doses of seltorexant. And the incidence of treatment emergent side effects was about 30.8% in the combined seltorexant group compared to 49% in the placebo group. And somnolence was more frequently observed in the 20 milligram group compared to placebo, similar to previous study findings. And no deaths or suicidal behaviors were reported in the main treatment phases. So the compound was generally well tolerated and did not demonstrate new or significant safety concerns, often showing a similar or better safety profile than conventional insomnia medications. So the primary endpoints for this study, this is a phase 3 study. Seltorexant significantly improved depression symptoms measured by the MADRS total score at day 43 compared to placebo. And the drug achieved all secondary endpoints for sleep improvements. And then, when compared to quetiapine, extended release over 26 weeks, seltorexant showed a numerically greater response rate, 57% versus 53%, through the specific difference. Although specific difference was not reached, or statistically significant difference was not reached for the primary endpoint. Significant metabolic advantages were noted, including significantly less weight gain for seltorexant compared to quetiapine, which we know is a major issue with this drug. Improved insulin resistance was also noted compared to quetiapine. For safety and tolerability, seltorexant was generally safe and well tolerated with adverse event rates similar to placebo and with a higher study completion rate. Okay. And for the, yeah, again, the same thing for seltorexant compared to quetiapine. There was significant improvement and and less safety concerns and side effects. And over to you, Roger.
Thank you very much to all my colleagues for their concise presentations. We're now going to have our panel discussion. Thanks in advance, everyone, for sending your questions in. Lots of questions. I'm going to ask my panel to be as concise as possible so we can have kind of a bit of a rapid fire here. Just to highlight one point, some of the data we've looked at is from already FDA-approved dual orexin receptor antagonists, so-called DORAs, like lemborexin. You also heard seltorexin, which is a so-called single orexin receptor antagonist targeting the orexin 2 receptor, which is an investigational agent. Question to my colleagues that has come in: what are the long-term risks of the orexin receptor antagonist? Is there a risk of dependence?
Roger, I can quickly address that. There have been a few studies with the dual orexin receptor antagonists spanning up to 6 months in some cases, showing minimal development of tolerance and also no rebound following rapid discontinuation. Certainly, the Schedule 4 agents, there's always a risk. In animal studies as self-reinforcement, there's always a risk of psychological dependence, but the pharmacologic studies have shown very minimal evidence.
Thanks, Carl, very much. Here's another question coming in. This is really a good question for the clinical ecosystem. If someone presents with insomnia, should we be looking for depression as the underlying etiology? Similar question: is there any difference in the insomnia of a person who has an insomnia disorder when compared to the insomnia we see in someone who has a depressive episode? Maybe Dr. Khan, you first.
So I would say it is very difficult to treat the insomnia if you don't treat the depression. Similarly, it's very difficult to treat the depression if you don't address the insomnia. So these are correlated. And yes, I always assess patients who are coming in for insomnia evaluation. I assess whether they have depression. That actually makes my job easier. If they have depression, I can use some of the antidepressants that have sedative side effects. Over to you, Carl.
Robert, quickly add to that, that I think it's the answer is also sometimes both, right? In other words, treating the depression is always the right way to go, as Dr. Khan mentioned. But on the other hand, the presence and persistence of insomnia in the context of a treated depressive disorder may contribute to an exaggeration of the depression and other problems later on down the line. So I think sometimes you treat both.
Yeah, well put. Here's a question coming in, and maybe I'll take the first stab at it myself. We've been hearing about insomnia. We've been hearing about the orexin. Could they, in fact, be preventing relapse by reducing hyperarousal? Carl, I'm going to give you that one, but before you do, I'm going to take this one. Could early use of these agents have any effects on metabolic systems? Great question. What I want everyone to be aware of is that the orexins, which are relatively new, in fact, they're Gen Z. They were only discovered in 1998. We have learned first the role in arousal dysregulation, such as sleep-wake disturbances. We're talking about insomnia today. but also narcolepsy is also another consideration for those who have deficiency. But this is only the first story. In other words, there's another part to this story, that being their role in reward motivation, the role in cognition, and also metabolism. Through central and peripheral mechanisms, they do modulate glucose insulin homeostasis. So the answer is yes. And stay tuned. There's been a lot of interest, and people in my lab, other labs are looking at this very question. As I see today's program, first of all, I start off by saying this program is going to be an example of theory to therapeutic, but I really think clinically the message is that dysregulated arousal systems are core features in depression and often residual in people who've been treated with conventional therapeutic approaches. That invites the need for assessment, but also invites consideration. What's the underlying pathophysiology of this? One mechanism being orexin signaling dysregulation, and that's what's provided the impetus for not just today's program, but a large research campaign to look at whether or not orexin antagonism or modulation broadly can in fact alleviate not just sleep disturbances, but also in fact related symptoms like depression, like you have seen today, in a way that's meaningful. And of course, it raises many questions about how they compare to alternatives and long-term outcomes for patients. So a really interesting area, a relatively new pathophysiologic target for us to consider, and very hopeful for patients. Our time, as always, goes very quickly on this program. I want to thank my colleagues for joining me. I want to thank all of you for participating and Medscape for their help in putting this together. And again, thank you very much to everyone for joining us.